our radiologist, Dr. Madoff. Are open stand-up MRIs as good as closed MRIs? There's a microphone. My experience is that they're nowhere close to being as good. The magnet strength, the magnetic field in the stand-up open MRIs is much, much less. The resolution is much, much less. If somebody is so claustrophobic they can't get an MRI, and there's some reason why they can't have conscious sedation by an anesthesiologist and have an MRI, they're better off with a triple phase CT. That's been my experience. You really have to have good imaging with high resolution to see little tumors. And I haven't been that impressed. I don't know. Do you have any thoughts?
I would agree. I think a poor quality MRI is a useless MRI. So I think that although the open MRI technology is getting better, a poor quality MRI is useless in management.
The one thing that I would add is that you want to get the imaging where you're really having your treatment, because I can tell you that it's almost comparing. I mean, the image quality, believe it or not, it's different even if you have an MRI at one institution versus another institution, and the reads are often different. And when we try to assess patients' response to therapy, sometimes the quality is very, 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 very subject. So I always, even if the patient has to come from long distances, I would still strongly suggest that they come to our place. I have no interest financially whether they come to my place or not. So, but as far as having accurate reads, having people that you can go over the images with, and do the necessary sequences, especially for MRI, I think that's essential.
I think that's basically true, but I think there's some people have insurance constraints and can only go to other places. And I think if you go to a quality center, one of the major university centers or a very high quality place, and you discuss the situation with the radiologist, and there's somebody who's really good and experienced at that center, and it still may be possible to use that information if you have the discs and you have the information.
Yeah, let me just add that keeping the discs is absolutely key.
That's absolutely essential.
So wherever you have your scans done, whether it be a CAT scan or an MRI, get a hold of those discs and you keep them, okay? Not your doctor, you keep them.
And the doctor can have a copy too. It's very easy to copy discs. You just put it in your computer and duplicate it. And I think that it's a good idea for patients to keep a copy and give a copy to all the physicians, especially in this community where people often go between multiple institutions. It's really important that everybody knows what's going on. So I would encourage that, to have all your doctors have the reports and the discs if they're involved in planning treatment. Okay, that leads to the next question, which is also a radiology question. People are really interested in radiology today. Why do you use MRI versus a CAT scan? Who would like to start with that one?
I mean, there's many different reasons. They actually give very different information, and one is that at least for me, MRI probably gives more information. Okay, but there's with tumors that you wouldn't be able to see otherwise on a CAT scan. Typically, if we do CAT scans, we get triple phase CAT scans. CAT scans can take seconds, as opposed to MRIs can take up to an hour or more. I recently had an MRI, and it was torture sitting in an MRI still for 45 minutes. So there's many reasons. There's a lot of differences in the contrast agents. There's some contrast agents that you use for liver cancers, for example, that are much more that show more liver function than other contrast agents. So I think that, and sometimes I'll actually alternate. Okay, sometimes if for patients that have chemoembolization, where you want to see, I talked about this briefly, but in conventional chemoembolization, Lipiodol, which is one of the agents that it's an oil that you mix the material with, it's radio opaque, which means that you can see it on on regular X-rays, and you can see it on CAT scans without contrast. So in patients that underwent conventional chemoembolization with Lipiodol, I would rather see that because MRI is it's very difficult to actually see the Lipiodol and where it's uptaken and things like that.
Any other comments on the subject?
I would agree with a lot of those comments. I think we individualize it based upon what kind of information we want and about the patient. A patient with a pacemaker, a patient with hardware may not be able to get an MRI. It still takes quite some time as well. So I do think that for evaluating the liver, the MRI ends up being a bit more of a superior test than a CT scan, but it has some of its disadvantages. But I wouldn't think of one or the other. Sometimes they're complementary to each other. And in some patients, we get both for critical planning purposes.
Okay, I can tell you from a medical oncology point of view, from my perspective, that for imaging the chest, there's no question that a CAT scan is superior to an MRI. There's still a problem with respiratory movement that makes it a little blurry. And you could usually get by with no intravenous contrast. Just practically a single breath hold will do a beautiful picture, and the lungs look black and white, water density tumors look white. You could see the difference, and it makes its own contrast. So I think that that's a wonderful study and uses very little radiation because it's just a single pass without contrast. The problem for abdomens is when you're looking at water density tumors inside of a water density liver, okay, you have to use intravenous contrast, and you have to do multiple scans of the entire abdomen and pelvis, early arterial phase, late arterial phase, venous phase, no contrast. You have to keep scanning. So you end up using a lot more radiation and for a significant amount of the body. So if you have especially young people with a very, very slow-growing tumor, and you're going to be following their tumor for the rest of their life with scans every 3-4 months, every 6 months sometimes, but when people have tumors that are starting to progress, very often every 3 months, it does limit the amount of radiation when you use MRI. In addition, for looking at the liver, as Dr. Madoff said, you can get, and the other panelists said as well, you get beautiful images of the liver when you use a contrast like Eovist. You inject it intravenously, but then it gets excreted into the bile. So you're getting a double whammy contrast for liver because it makes the bile contrasted and the arteries and the veins. So with that combination, you could sometimes see liver tumors down to just a couple of millimeters. It's as good for looking at liver in many cases as a gallium dotatate PET. It's really wonderful for seeing little liver lesions. So I think that for this particular purpose, for following neuroendocrine tumors, it's really great. So I think that everything that's been said about alternating and using other tests and using CT is very important if there's any contraindication to an MRI, or if you need to look at specific structures or the Lipiodol contrast or anything that requires CT. By all means, CT is the way to go with people that are too claustrophobic, and there are many reasons why you might want to get a CT. The other thing about alternating is that when people are on clinical trials or being considered for eligibility for clinical trials or being monitored for disease progression, you like to have the same modality used over and over. People use something called RECIST criteria for evaluating response. If you measure a tumor and it's 2 centimeters and you measure it again and it's 2.3 centimeters, you know, is that progression or is that not progression? If you're going from an MRI to a CT, you might see differences in the size of a tumor just because of the technique, and you can't compare one very well with the other. So I think that it's a good idea to have one that's being used as a primary for evaluating whether the cancers are starting to grow or not grow. And it really can be done just as well, potentially, with either one if it's done properly. But it's a little tricky, and it's something you really need to discuss with your treating doctors, I would say, to figure out which one to use.
Well, that's the other reason why I think that it's critical to do the imaging at the same institution, whether it's your institution or another one. But if you keep getting it at the same institution, hopefully the quality will be the same.
Right. There are differences in the techniques of how people go about doing these studies, especially MRI. It's a little bit tricky. We have a special protocol the way we do it with diffusion imaging and certain criteria and the contrast and the way it's done and the way the pictures are done. And there are different approaches. Okay, let's move on. if there's an elevated pancreastatin and serotonin, but the PET scan is negative, what would be your next step? I presume they're talking about an FDG PET because that's the one that has been most commonly available. And presumably it's somebody who doesn't have any other sign of malignancy, but has previously been treated. Let's say we make those assumptions. What does it mean if the pancreastatin and serotonin are elevated, but the FDG PET is negative? Who would like to tackle that one?
Well, I never actually use one point in time. So I like to look at a trend. So let's look at the two possibilities. One possibility, as this is a new finding, the pancreastatin and the serotonin had been normal, and now it's elevated, and the PET scan shows no disease, or it can't find disease. First of all, I don't do FDG PETs for carcinoid neuroendocrine tumors at all. Okay. There may be a place for it for some of the high-grade, rapidly growing neuroendocrines, but in general, I don't use FDG PETs because FDG PET is based on metabolism of glucose in highly aggressive or highly metabolic tumors. That's not the typical neuroendocrine tumor. So to me, the test is really not a test. So if this is a patient where previous labs were normal and now they're spiking up, I would go on and do, this is one instance where I would do an Octria scan again, but I prefer to do the gallium if it's available. And that's the test I would do to look for recurrent tumor.
Yeah, I agree completely. FDG PET has very, very limited role. It's based on how fast the cells are metabolizing sugar. And neuroendocrine cells don't eat a whole lot of sugar because they're not growing very fast. And you could have a completely negative PET scan. And I actually have several patients that have a situation like a small breast cancer is discovered, and the patient has a PET scan to stage the breast cancer, and the PET scan showed only the tumor in the breast. So the patient had surgery and radiation and chemo, whatever they had for their breast cancer. And then after they were all done, somebody got another CAT scan. Except instead of doing it as a non-contrast CAT scan with the original PET, they had a contrast. It was a contrast CAT scan, and it showed 10 liver metastases. And they said, you're dying of breast cancer. And then they did a biopsy and found it was really a neuroendocrine tumor. Okay, that's because the FDG PET never showed those tumors that were there all along. The patient had two malignancies going on all the time, but only the original breast cancer showed up on the FDG PET. And then when the contrast study was done later on, it showed those metastases in the liver. So you just have to realize the FDG PET is a very poor scan. And I know some people keep getting them over and over and over for neuroendocrine cancer. I'm not really sure why.
I don't think I've ever ordered one for
No, I agree.
Well, the thing about FDG PET is that the sensitivity is, you need to have tumors greater than at least 1 centimeter. So regardless for neuroendocrine or any other cancer, because I'm sure in this room or any other room, people, neuroendocrine cancer isn't what we talk about. So if someone came to me for another type of tumor and they had one PET lesion, PET positive lesion, and I was going to do an ablation on that patient, I would still get an MRI or a contrast enhanced CT because I had been burned where I was literally going to do I think it was a pancreatic cancer met to the liver. The patient had one lesion, and when I did an ultrasound prior to getting the patient under general anesthesia, there must have been 20 lesions.
Right.
And they were all smaller than 1 centimeter.
Right.
So then we immediately did a triple phase CAT scan and saw there were many more lesions, and that completely changed the therapy that we were going to do.
Right. So the PET scan of choice, if anybody ever needs a PET scan for a well-differentiated neuroendocrine tumor, is clearly the gallium-68 dotatate PET. That's another story. We have an immunotherapy question here. New York Times had an article about a patient with KRAS, presumably a KRAS mutation, responding to immunotherapy. How is KRAS different from other things that can be going on in a cancer cell?
KRAS for neuroendocrine tumors? I don't check KRAS.
I don't know what this is about. It doesn't even mention what that New York Times article said. I suspect it was not a neuroendocrine tumor. But yeah, it might have been breast cancer. Yeah, that would make more sense. But
So, I mean,
Comments?
the only time I check for KRAS is in colon adenocarcinoma, where in those situations, they're KRAS wild type. We could do EGFR inhibitors as an option to treat those kinds of patients. To this date, I've never checked a KRAS in neuroendocrine tumor. When I mentioned BRAF, I thought that was pretty exciting because that was a colon neuroendocrine tumor, high grade, and BRAF mutated, which we found out in next-gen sequencing tests. And sure enough, there's case reports on it, and now it's become something I check in all my colorectal neuroendocrine tumors. I don't know if that's the right thing to do, but I'm doing it. And this guy had a platinum therapy and temozolomide, and no response to platinum, and maybe 4 months with temozolomide. Maybe 70–80% liver disease, liver burden, and had a BRAF MEK inhibitor off-label, which is a drug we use for melanoma. And it melted his skin. It went from 70–80% down to 10%. And that gave him about a good 6 months, and now recently just progressed. So I do check BRAF for the neuroendocrine tumors from the colon. I'm not sure what the BRAF incidence is for other neuroendocrine tumors, but I'd be curious.
So let me just make a comment about these molecular tests in general. We've had molecular tests for quite some time, but we had very limited number of molecular tests. For example, we have HER2/neu for breast cancer. Now that's been around for decades now, and we know that in a HER2 positive breast cancer patient, this is a highly aggressive cancer, but also highly susceptible to the drug Herceptin. So we have a marker, and we have a target, and we have a treatment for that. We're now recognizing a whole slew of other molecular markers, molecular tests, molecular markers we can do on a vast array of cancers. It does get confusing. And many times, I don't know if you, but for me, many times I have to go to a table and look up what the marker is, what the target is, what I can use for the patient, etc. And it's going to get more and more and more confusing as we accumulate more data and what we call actionable data, data that we have an action for. And it's exciting, but it's a lot of information coming, and it can get confusing.
Okay, next question. Do you know any problems with receiving both lanreotide and Faslodex for breast cancer at the same time? I have approximately 25 patients who have carcinoid tumor and breast cancer both at the same time. It's possible that there's actually an increased risk of breast cancer, colon cancer, and a few other things with carcinoid. But in any case, there's not any problem at all that I could see using an anti-steroid hormone, an anti-estrogen, which is Faslodex, and using an antipeptide hormone, which is lanreotide, for treating the neuroendocrine cancer. They're completely unrelated, and I have plenty of patients on both anti-estrogens and a somatostatin.
You may run out of injection sites.
Hmm?
You may run out of injection sites between Faslodex and lanreotide.
Okay. Any other thoughts? Okay. Next one. A patient's daughter was diagnosed, presumably with a neuroendocrine cancer, and presumably the patient also has a neuroendocrine cancer. Is there a high risk of hereditary disease, and is it being reported?
The answer is yes, and there is an NCI study going on where I highly suggest the patient contact the NCI or have their doctor contact the NCI on their benefit, and hopefully they can get enrolled in the study.
Right, so familial carcinoid is a very, very rare disease. There are just a handful of families in the whole United States where it runs in families, which is why we usually tell patients it's not hereditary, your kids are going to be okay and everything's fine. But there are some families where all the family members are popping up left and right with carcinoid tumor. If anybody has a sibling, a parent, a kid who also has a neuroendocrine tumor, they can go to the doctor at the NCI, as Dr. Gerstein said. His name is Dr. Stephen Wank, W-A-N-K. He's very good, and anybody who goes there is able to get free gallium-68 dotatate scans. They have fluorine-18 fluorodopa scans. They have all kinds of things that are possible. It's all given for free, and they'll screen other family members for free. And they've actually found a genetic defect in certain families that can be used for screening. The most common familial cancer syndrome by far is not in carcinoid, but in pancreatic neuroendocrine tumor, where MEN1, multiple endocrine neoplasia type 1, with parathyroid tumors in the neck, pituitary tumors, and pancreas tumors, and then other kinds of foregut carcinoids can all happen in multiple family members. That's very, very rare, but of the familial syndromes, it's the most common. And then we already heard in previous talks about von Hippel-Lindau and NFL1 and all these other syndromes. But those are very, very rare, and families that have it tend to know it pretty early on.
Most well-versed genetic counselors at facilities can handle the genetic analysis for hereditary pancreatic neuroendocrine tumors. Very different than for the midgut, as mentioned.
Okay, and then we have a question about immunotherapy. Also on the subject of immunotherapy, I just wanted to remind people that there is a trial which is just about to open. I think we're going to probably be open in the next 2 or 3 months using a immune checkpoint inhibitor that works on the PD-1 interaction of a new drug that's similar to pembrolizumab and ipilimumab, which is made by Novartis. And that's going to be specifically for neuroendocrine cancers, grade 1 and grade 2, whether it's lung, thymus, intestinal tract, small intestine, large intestine, pancreas, at any site. And if people are progressing on other things and need an immune checkpoint inhibitor, it will be provided for free through this clinical trial mechanism. It's a little bit easier for people to get it, compassionate use kind of things like was previously mentioned for high-grade neuroendocrine tumors. But for the people that have the lower-grade tumors, where we all have anecdotal responses like the one you heard today, but we don't really know what the true response rate is and the true effectiveness, I think it's certainly a hopeful option. And just be aware there is such a trial that's about to launch. Okay, here's another question about immunotherapy. Lately, many patients who had immune therapies are coming down with unforeseen effects. What is being done to prevent patients with neuroendocrine cancer from having basically side effects from these medications?
Yeah, some of the side effects are very unique and different compared to chemotherapy and targeted therapy. You got to imagine where you're trying to boost the immune system, so the immune cells are, you hope to go after the cancer cells, but can also attack normal tissue, so it can attack the skin, the GI tract. And any organ of the body, you name a inflammatory reaction or autoimmune reaction to an organ, it's been seen with immunotherapy. Most of this is reversible. On average, anywhere from 2 to 4 weeks, most patients will respond to oral steroids and come off the steroids within in a very short period of time and not have a recurrence of their immune-related issue. That being said, I have some folks, I think now, because I do a lot of the combos, that every 2 or 3 months I have to admit folks to the hospital and do IV infliximab, Remicade, probably heard of vedolizumab to shut down the T cells that are going into the colon and causing the immune colitis issues. And so I do have some folks that here they are 2 or 3 months later having these persistent colitis, diarrhea issues, and we have to use stronger medications to shut it down. But for most people, it tends to be a temporary fact. The one irreversible issue is the endocrinopathy. So we do see some irreversible hypothyroid and adrenal insufficiency. And the good news there is a quick fix. You just replace the thyroid. And if the thyroid is not working, you give them Synthroid. If your adrenal's not working, you give them hydrocortisone. It could be a really easy fix. And as we as medical oncologists now have to be endocrinologists and treat these patients. That typically is a more irreversible issue, but for most other immune-related issues, they can be shut down with steroids.
The key is to be aware of these side effects and be aware that you really need to be carefully monitored, and the doctor seeing you should know what's going on. One of the really major hazards is that somebody gets treated somewhere and then goes to a little community hospital where nobody's ever heard of it before, and they're lying in the hospital dying of a colitis that could potentially be stopped. And all kinds of bad things can happen if you are not aware of the side effects, and the doctors are not aware of side effects. So it really is something that is a potential problem.
And we definitely want to emphasize that because a lot of times patients are thinking, well, if I have this adverse effect, they're afraid to call in and say anything about it because what are we going to do? Or what are they afraid the physician's going to do? They're going to hold this drug.
Right.
And so that could be a problem. I had a guy probably 4 or 5 years ago where he was going 10 times a day, every day for 3 weeks. He didn't call in. And when he came in 3 weeks later, he had a pretty bad perforated bowel. And so sometimes the patients are pretty sort of afraid that we're gonna hold the drug. But the point is not how much drugs you get. It's not about how much dose you get. It's about turning on that immune system for a moment in time, let it do what it does. But when it starts to hurt the patient, we need to shut that down as soon as possible. Otherwise, these immune-related issues can kill patients. You can die from liver failure, colitis, and even severe endocrinopathies and a whole host of other problems. Myocarditis, pneumonitis, just to name a few.
The other thing that was already mentioned again in your talk, but just to emphasize to the group, that when you use a single agent PD-L1 inhibitor medication, the incidence of having these kind of severe side effects is probably not more than 1 in 20. But as soon as you add combinations with the anti-CTLA-4 drugs and other immune drugs at the same time, the incidence of really major complications goes way up. And even though the response rate might be higher, you're risking severe toxicity and really needs to be given with extreme care.
The Yervoy ipilimumab is a very toxic drug. As soon as you combine anything with it, chemo or BRAF/MEK or PD-1s or other immunotherapeutics, you can get significant toxicity issues. Not just one organ, but 2, 3 organ systems all at once, and that needs to be shut down.
Many patients have had a concept drummed into their heads by oncologists who have had this concept drummed into their heads over the years of dose intensity. Okay, so it used to be when I was training, it was dose intensity. Get more dose into the patient, a higher dose. You want a bigger response, you get a bigger dose. Okay, that's I think that's by and large gone, except for acute leukemias or very aggressive lymphomas and things like that. As we've turned cancer, as Dr. Wolin mentioned way back in the yesterday when he was speaking, as we turn cancers into chronic disease, it's not so much dose intensity that we want. We want to be able to coax these cancer cells into doing what we want to do. In immune therapy, we want to coax the immune system into doing what we want it to do. That doesn't necessarily mean we have to keep the doses up. It doesn't necessarily mean we can't skip a dose now and then to ameliorate some of the side effects. So dose intensity is a concept that I think it's had its time.
Yeah, absolutely. I've had folks who had only 1 or 2 doses. You're supposed to get 4 doses of CTLA-4, 1 or 2 doses, bad reaction, so we shut down the reaction and controlled the side effect, but here they are, the cancer's well controlled years out without cancer coming back. And so again, just 1 or 2 doses, turn it on for a moment in time, it can be pretty impressive.
Okay, so those are the questions that have come from the audience so far. But don't be shy. As I said before, if you could think of anything, you could either come to a microphone, write it on a card is the best, and pass it in, and we'll discuss it. Meanwhile, I could just throw a few questions at the panel, and if anybody in the panel wants to talk about anything controversial and ask the rest of the panel, that's great too.
I have a question.
Sure.
About immunotherapy. So basically, a lot of the techniques that we do in interventional radiology, the goal has always been to try to, and I said this in my talk, eradicate the entire tumor. Right? So there's been some discussion about trying to not necessarily kill the entire tumor, but treat the tumor to the point where you get antigens released that then you can combine with immunotherapy to do some kind of synergistic response or some kind of basically synergy between immunotherapy, anti-tumor therapy, or ablative therapy. So what are your thoughts on that?
Oh, absolutely. I think one point we can make out of the melanoma world is if you give ablative doses of radiation therapy to a spot, and ablative dose of radiation to literally kill cancer cells, you're creating those cancer-specific antigens, and you're getting responses in distant sites that weren't treated. You're not even getting immunotherapy. Right? That's the abscopal effect. Mm-hmm. And so now doing that in combination with immunotherapy, I think that makes good sense. I think in the lung cancer and melanoma, when you do chemotherapy, I'm not seeing a synergistic response or a better response from above and beyond. I'd be curious to know what liver-directed therapy in combination with immunotherapy might do. I don't know any data.
And likewise, immunotherapy after PRRT. Yeah. I think any type of radiation potentially can induce the mutational load in the cancer cells, and we have to see how that develops. I have another immunotherapy question for you. In recent years, we've gotten a little bit more brave in using immunotherapy in people that otherwise might have been thought to be at risk. For example, treating people with lung cancer with limited pulmonary reserve with PD-L1 inhibitors. Okay, and usually you can get away with it if you have to stop. If pneumonitis starts developing, you stop it. You do it anyway. But when people have mild, well-controlled autoimmune diseases like colitis, they're usually excluded from use of immunotherapy. Should these people also be given a chance? If you have to stop after 1 or 2 treatments, you do, but meanwhile don't close the door and not let them have any immunotherapy at all.
So I think the last example of that is when where you gave PD-1 to folks who had prior severe colitis due to the ipilimumab, and then you give the PD-1, and I didn't see those colitis issues. So I have no problems giving folks a PD-1 inhibitor
Right.
with pre-existing autoimmune conditions, or if they have prior colitis related to the ipilimumab. That as well as if they're HIV or Hep B, Hep C, those kind of things don't worry me. There's actually case reports that folks can do well with immunotherapy. There's case reports on organ transplantation, right? You can actually give immunotherapy in those situations with PD-1 inhibitors specifically.
Yes. Yes.
I've had a couple folks with ITP, Crohn's. I've had 2 folks with multiple sclerosis, where I've given them combination actually, CTLA-4 and PD-1, and not seen an exacerbation of their issue. The reason I gave the combo because I did check a PD-L1 on them, it was 0%, and I gave combo because I thought that was going to give her a best shot. And I did not cause an exacerbation of her autoimmune condition, but I did give her adrenal insufficiency, and then fixed that pretty easily. She's got a complete response. So these are things to worry about, and maybe have a risk-benefit discussion with the patient. But PD-1, I'm less concerned. For CTLA-4, I am a little concerned. There are case reports where you gave CTLA-4 for folks who had pre-existing autoimmune conditions like multiple sclerosis, and you caused some big problems there. And so these are things that need to be talked about.
Okay. A question for Dr. Madoff. How do you see the role of using radioembolization to obliterate a section of liver that has tumor in it? Just use it as an alternative to surgery in somebody who's not a good surgical candidate.
Well, radioembolization. Well, first of all, we have done that in HCC patients. Patients with primary liver cancer, where we did transarterial therapy, and then we followed patients with portal vein embolization.
Right.
So you basically treat the artery and the portal vein. Because I said before that the artery supplies most of the tumor and the portal vein supplies most of the liver. Well, if you just basically shut down both lobes, the whole area will, it could potentially necrose, but ultimately you can treat the tumor. We've had patients do really, really well with that. As far as giving high radiation doses to the liver by radioembolization, that I'm sure has also been done. Now again, these are mostly in patients with cirrhosis with HCC. Now I wouldn't necessarily do that in patients with any kind of metastatic disease, because you can influence the metastases to actually grow faster than they would have otherwise. So one of the downsides of portal vein embolization has been that if there aren't any tumors in the remnant liver, the part that you're not embolizing with the portal vein, you can incite tumors to grow faster than the actual liver is regenerating in itself. So in the setting of metastases, I probably would not suggest that. But in the setting of cirrhosis with patients that have primary liver cancer, that actually is a good option.
Okay, and a question I have for Dr. Sesson. What is your feeling about the role of a palliative Whipple doing radical pancreatic head resections in the presence of liver metastases?
That's a great question. I think there's 2 points to it. One, obviously, the Whipple operation is a large operation associated with a whole host of potential complications, including a small but not negligible chance of dying from the operation. But the more important factor is in how do we control the disease to the liver. So in patients who have disease in the liver and disease in the head of the pancreas, if we are going to do therapy to the liver, I almost invariably want that therapy to the liver, particularly any regional therapy, to be done before a Whipple operation. We do know that doing Whipple operation and then doing liver-directed therapy runs the increased risk of developing liver abscesses. And I've had some patients who've had embolizations after Whipple operation who've had chronic problems, lifelong, from multiple infections that were difficult or impossible to control. So I think if we are to do a palliative Whipple, we have to do the liver-directed therapy first, and then I'd consider doing a palliative Whipple. I have to give it a lot of thought because of the long-term implications of difficulty
tomato.
No, I agree.
Okay, so that's very important because once you start getting liver abscesses, you can end up.
I think that's the value of having, we talk about this team, concept, so even though we could do liver-directed therapy, we can do Whipple operations, we can do all these options that were mentioned, making sure they're done in the correct order is sometimes critical. Sometimes it's not that important, but sometimes it is. And knowing when it is very, very important, extremely important. You could really burn some bridges doing it that way, and so it does take careful planning.
Well, just as a side note, embolizations have been done and are being done after Whipples, and these patients are usually pre-medicated with a bowel prep regimen, antibiotics, etc. It used to be that any patient with a bilioenteric anastomosis was not considered a candidate for Y90 radioembolization, for example, but now it is being done, and as long as there's a good bowel prep regimen.
Okay, so it just has to be done carefully. The idea is if you take out the head of the pancreas and reroute all the plumbing, that bacteria that you swallow when you eat, that go in the stomach and the duodenum and the beginning of the small intestine before they've had a chance to be digested, those bacteria get into the bile duct and then go into the liver and infect the liver. And that can happen much more easily when you reroute the plumbing in the beginning of the intestinal tract. Okay, did anybody have any other questions?
Let's go back to, I guess, your question from before, which was about ablative doses of Y90.
Yes.
So I guess at some point I missed part of the problem, which I was thinking of more of a lobar treatment. However, on various types of cancer, when you do have very focal types of cancer, whether it be even if it's neuroendocrine, if you have one large mass, you could use ablative doses, a much higher dose given to one area,
Right.
and you could just completely fill that area and it would be less. I guess it would be less morbid than doing a combined arterial portal embolization, which you probably wouldn't do in neuroendocrine anyway.
Right, and these would be patients that would have masses that would be too big to treat with radiofrequency ablation or microwave ablation or other standard types of ablation.
Right.
So I guess if there are no other questions from the panel or the audience, I want to thank everybody and let the Womans have a chance to wrap things up.